Good morning. Today we will discuss about steroid resistant nephrotic syndrome. So we have discussed about nephrotic syndrome and its case presentation in our previous video. So here we will talk about steroid resistant nephrotic syndrome. So what is the triad of nephrotic syndrome? It's just a recap of our previous video. So triad of nephrotic syndrome according to our present definition is nephrotic range proteinuria, that is 40 mg per meter square per hour. Okay, next is edema, and next will be hypoalbuminemia. Hypoalbuminemia in this nephrotic syndrome is defined as serum albumin less than 3 gram per deciliter. Okay, so this is a triad of nephrotic syndrome. So on going on to a steroid resistant nephrotic syndrome. Before that, what is complete remission in a steroid sensitive nephrotic syndrome? So when do you call it as a complete remission? Okay, fine. So complete remission is after 6 weeks of treatment with prednisolone at a dose of 60 mg per body surface area, that is 60 mg per meter square per day. After completing that treatment, you will see the urine dipstick or urine protein. So you will see for urine protein. So urine protein should be in the amount of nil or a trace in the dipstick method, or urine protein by urine creat. Urine protein by urine creat ratio will be less than 0.2 or 24-hour. This is 24-hour protein, urinary protein. 24-hour urinary protein will be less than 100 mg per meter square per day. So this this is called as complete remission when you give to start a child on treatment with a prednisolone at a dose of 60 mg per meter square per day for about 6 weeks. Okay. When you call it as a resistant, in resistant, that is steroid resistant. In steroid resistant itself, we have two types. One is initial resistant, another one will be late resistant, or also called as secondary steroid resistant. It is late steroid resistant, or it is called as secondary steroid resistance. Okay. Initial resistance is failure to achieve complete remission after 6 weeks of prednisolone therapy. So it is failure to achieve this complete remission, this criteria. So failure to achieve complete remission after 6 weeks of initial therapy. It is called as initial steroid resistant. Then what you call it as late or secondary steroid resistant. It is initially the child is steroid sensitive. The child will become a steroid resistant in a subsequent relapse. So initially child has responded. That is initially child is steroid sensitive. Child will become steroid resistance in further relapse, in subsequent relapse. That is called as late steroid resistant or secondary steroid resistant. Okay. Next. That is when you call it as a resistant case, that is they are not failure to achieve this complete remission. So when do you call this as failure to achieve complete resistance? Here also you will check your urine dipstick test and everything. No, so that is when the urine protein is still in 3+ or 4+ in urine dipstick test. Urine protein by urine creatinine ratio is more than or equal to 2, or 24-hour urine protein. 24-hour urine protein is more than 1000. It is more than 1000 mg per meter square per day, and the serum albumin, or the child is having edema without resolving edema with serum albumin level of less than 3. That is your criteria for nephrotic syndrome. The child has not responded to your steroid therapy, then you tell the child is having a failure to the treatment or non-responder. Then you call the child as non-response or steroid resistance. Fine. Here in this steroid resistant, you have partial remission also. What you call this as partial remission. Now when you call the child to have a partial remission, here the child will have urine protein. Here the urine protein will be 1 plus or 2 plus. With urine protein by urine creatinine ratio will be 0.2 to 2. 24-hour urinary protein. 24-hour urinary protein will be between 100 to 1000 mg per meter square per day with serum albumin level. Here this is the point. Okay, in partial remission, the serum albumin level will be more than 3 gram per deciliter and the child will not have edema. So edema will be absent. Then you call the child to have a partial remission. Okay, this can be asked in your viva session. What is non-response, what is partial remission, what is steroid resistant, initial steroid resistant and late steroid resistant. Next, what are the investigations when you find a child to have a steroid resistant nephrotic syndrome? So the initial evaluation of a child with steroid resistant nephrotic syndrome, you have to do urine analysis, microscopic urine analysis, whether the child is having microscopic hematuria or not. Okay, urine analysis. In that urine analysis, microscopic hematuria, you have to look for the dysmorphic RBCs and all. Okay, next you look for spot urine to urine protein to creatinine ratio, CBC. Next you will do serum electrolytes, albumin, HbA1c. HbA1c is done to check whether the child is having any toxicity towards steroid, because you have given steroid for about 6 weeks. Next you will look for cholesterol levels. Okay. Next you have to look for HbsAg, HCV and HIV. Why this? What is this? Your viral markers are being tested is because when you start a steroid resistant nephrotic syndrome treatment, next you will go for calcineurin inhibitors. So before starting calcineurin inhibitors, you have to look for this viral markers, because after calcineurin inhibitors you might also be going to start this rituximab and all. So this rituximab can stimulate the HbsAg. The child can also be HbsAg positive after being given treatment with rituximab. So before that you have to check for this viral markers. Next you do ultrasonogram of kidneys. Next is kidney biopsy. Kidney biopsy we have discussed in our previous video. What are the indications for kidney biopsy? Here before starting treatment with calcineurin inhibitors, because this calcineurin inhibitors are nephrotoxic, you have to do a kidney biopsy before starting treatment with this CNI, that is calcineurin inhibitors. In kidney biopsy you have to look for light microscopy, immunofluorescence. This is immunofluorescence and electron microscopy. Okay. Next, in kidney biopsy you will be getting in histopathological of kidney biopsy. You will diagnose the child to have 40 to 50 percentage. 40 to 50% of the children with steroid resistant nephrotic syndrome will be found to have focal segmental glomerular sclerosis, and 25 to 40%, this is 25 to 40% will find be having minimal change disease. Next, 5 to 8% can have mesangial-proliferative glomerular nephritis. Okay, this is the findings you can get in a child with steroid-resistant nephrotic syndrome in a kidney biopsy. Next is next test. This is the 8th one, kidney biopsy. 9th is genetic study. whom all will you do a genetic study? So what is the difference between a kidney biopsy, for the children, indications for doing a kidney biopsy and indications for doing a genetic biopsy? Sorry, genetic test, not biopsy, sorry, genetic test or genetic study. So genetic study indications are when the child is having a congenital nephrotic syndrome. So indications of for genetic analysis or genetic study. One is congenital nephrotic syndrome. What is congenital nephrotic syndrome? When a child presents with the features of nephrotic syndrome in less than 3 months of age is called as congenital nephrotic syndrome. Here you can find the mutations in genes such as NPHS1, NPHS2. Next you can find in this WT1 gene. The syndromes associated with the congenital nephrotic syndrome are Danish-Dash syndrome and Finnish type syndrome. And you can also find mutations in LAMP2, CoQ2. Okay. So these are the mutations that you can find in a congenital nephrotic syndrome, and if the child is having mutation in any one of these, then you find the child to have a monogenic form of disease or monogenic, they find the child to have monogenic disease or monogenic nephrotic syndrome. Okay, fine. Next indication is, one is congenital nephrotic syndrome, another one is initial resistance. Next one is initial resistance, that is occurring during infancy. Next is nephrotic syndrome with features of extrarenal. Nephrotic syndrome with extrarenal features. Fine. Fourth, non-response to calcineurin inhibitors. You started on the child with the calcineurin inhibitors, but the child is non-responsive to calcineurin inhibitors. Fifth, when there is a family history of steroid resistant nephrotic syndrome. Next is prior to transplantation, kidney transplantation. Okay. So these are the indications for a genetic test in a child with a steroid resistant nephrotic syndrome. Okay. Next, what is the uses of you doing this genetic testing? Advantages or uses of doing this genetic testing. One, you can counsel the parents. You can counsel the parents regarding the progression of the kidney disease. Regarding the progression of kidney disease can be counseled. Second, you can use a targeted therapy. Suppose if you find a mutation in a mutation in coenzyme Q10 defect. Sorry, I've changed. If you find a defect in CoQ pathway, if you find a defect in CoQ pathway, then you can start the child on with a targeted therapy, that is with coenzyme Q10 for the defects of CoQ pathway. Next, you can tell the parents, counsel the parents regarding future pregnancies and for antenatal diagnosis. So this facilitates a screening of live related renal transplant donors also. Fine. So these are the main uses for doing a genetic test in a child with steroid resistant nephrotic syndrome. Next we'll go on to the main heading, that is therapy. Therapy for a child with steroid resistant nephrotic syndrome. Fine. So the first line drug for steroid resistant nephrotic syndrome is calcineurin inhibitors. Among these calcineurin inhibitors you have tacrolimus and cyclosporin. When you use tacrolimus is being used for most of the child because of minimal side effect compared to cyclosporin, but tacrolimus can cause seizures. Side effects I'll write it here. Side effects, it can cause seizure, hypoglycemia, Next, the it is a nephrotoxic one, so it can cause AKI, nephrotoxic, and it is also a hepatotoxic also. This both cyclosporin and tacrolimus both are nephrotoxic and hepatotoxic. This cyclosporin can be associated with hirsutism, gingival hyperplasia, okay, hypertension. These are the side effects of tacrolimus and cyclosporin. But initial treatment is this both only. Among these both, you will use mostly tacrolimus can be used. Okay. Next, we suggest continuing therapy with calcineurin inhibitors for at least 24 months if there is a partial or a complete remission is achieved. So I'll tell the flow chart for how you're going to start the treatment. Okay. First, you do a basic evaluation, genetic testing, everything is being done in a child with steroid resistant nephrotic syndrome. Okay. After that, if the child, you find the child to have a non-genetic disease, then you start the child on with the calcineurin inhibitors along with the tapering dose of steroid. In tapering dose of steroid, you give the child with 1 to 1.5 mg per kg on alternate days. This is AD's alternate days for about 4 to 6 weeks is being given, and this steroid is being tapered for over 6 to 9 months. Excuse me. Next, after you start the child on with the calcineurin inhibitors with the tapering dose of steroid, you are going to assess the response to the treatment after 6 months. So when you assess the response to the treatment after 6 months by using like your this urine protein, creatinine, everything. Okay, then you have to look even for AKA. So when you find the child to have a complete response is being present. Complete response meaning urine protein less than 100, it means 24-hour protein less than 100 mg per meter square per day, or urine protein by creatinine ratio is less than 0.2. So when you find the child to have a complete response or a partial response is being present, then you ask the child to continue the same CNI, that is calcineurin inhibitors, for 2 years is being continuous along with tapered dose of steroid for about 6 to 9 months. Next, once the child is being non-response to the above treatment with the calcineurin inhibitors, then you have to rule out genetic disease once again. You have to rule out genetic disease. Next, you have to consider the child to being treated with rituximab. Fine, you have to give rituximab to the child along with, or you can combine calcineurin inhibitors with mycophenolate mofetil. Next, you have to look for whether the child is being non-response or responsive. This is response or non-response. Okay, when the child is being non-response, you have to withdraw this immunosuppression and give only supportive management. You have to withdraw the immunosuppression and you give only supportive treatment. Next, this is about non-genetic disease. Once you find the child to have a genetic disease, everything is a supportive management only here. Give a supportive management by giving ACE inhibitor or ARBs. Counsel about risk of kidney failure and also prepare the child for kidney transplantation or renal transplantation. Okay. So this is about the treatment for a child with steroid resistant nephrotic syndrome. Main first line is tacrolimus or cyclosporin. Next, whether non-responsive to the drug, then you have to use rituximab. In rituximab, you will be taking CD19. CD19 is taken as marker when you start a child with a rituximab. You have to target the CD19 count to be less than 5 microliter or less than or equal to 1% of lymphocyte count. this is taken as a target. So it is given in a weekly regimen. You are giving this rituximab at the dose of 375 mg per meter square. Weekly it is being given 2 doses. After giving these 2 doses also, the child is not getting a targeted CD19 or lymphocyte count, you can give an additional of 1 or 2 doses can be given for a maximum of about 4 doses can be of 4 doses of this rituximab can be given. Okay, so this is about the steroid resistant nephrotic syndrome. Thank you.